to all the participants who've joined this webinar. So this is a part of our project, the Climate India, looking at the climate change impact on brain infections. As a part of an educational initiative, we'll be rolling out the series of webinars focused on one particular brain infections as a broad theme or as a disease-specific themes. And we'll also have climate-related webinars as well. So this month, CMC Vellore will be hosting this webinar, and we have delegates who will be presenting. So it's my pleasure to have Dr. Ajith Sivadasan. He's professor and head of Department of Neurosciences at CMC Vellore, who will be giving us the first talk on the neurology of arboviral encephalitis. And we'll have Dr. Asha Abraham, who's the senior professor in the Department of Clinical Virology at CMC Vellore, give the second talk on the diagnostic updates. And to moderate, we have Dr. Priscilla Rupali. Ma'am is the head of infectious diseases at CMC Vellore, and I'll be co-moderating with her for this webinar. So now over to Dr. Ajith for the first talk.
Thank you. At the outset, thank you, Dr. Angel, for giving me the opportunity to present in this webinar series. And greetings to Dr. Priscilla ma'am and Dr. Asha ma'am also. So I'll be just sharing the slides. Is the slide visible, Angel?
Yes, visible.
Yes. So good afternoon. The first talk for today will be the neurology of arboviral infections, more specifically arboviral encephalitis. So this will be the outline of the talk. We'll have a brief introduction followed by a epidemiological perspective of the entire problem, some description about the pathogenesis of how arboviral infections cause meningitis, encephalitis, and myelitis and other devastating neurological complications. What could be the clinical spectrum of manifestations and how do we diagnose it? What are the specific etiological agents in the wide spectrum of etiologies of arboviruses which can present with encephalitic illnesses, and what we can do regarding the prevention and management of these problems. So arboviral infections usually denote infections which are caused by arthropod-bound viruses. These mainly are RNA viruses, belong to different classes. They usually require a life cycle in both the host as well as the infection is propagated between different hosts by the vector. And the majority of the arboviral infections are seen in tropical and subtropical regions. There is a complex interplay of host factors, vector factors related to the vector proliferation, as well as environmental factors, which lead to propagation of these infections, which has been more and more seen over the last 2 to 3 decades, especially over the last 2 to 3 decades. Climate change, of course, plays a major role in propagation of these infections. Most of these arboviral infections, these arboviruses have multiple cycles in which they survive in the environment. It could be an enzoonotic cycle, a sylvatic cycle, and sometimes even an urban and epidemic cycle. And usually the humans are affected when this urban epidemic cycles come into picture. And one unique feature of these arboviral infections is that a lot of these arboviruses have a neurotropism, that they have a predilection to involve the central nervous system or the peripheral nervous system, or in majority of the other cases, say something like dengue, the neurological involvement can be part of a multi-system involvement. And one more unique feature of these arboviruses is that sometimes the main manifestations and damage are caused due to direct inflammation and infection, but there could be a secondary autoinflammatory response to the viruses, which may lead to, just like any other infection, which can lead to devastating manifestations and sequelae. So going on to the recent public health trends regarding these emerging infections, anthropogenic climate change, especially with regards to arbovirus infections getting more and more, is very important, because with higher temperatures, very unpredictable rainfalls, which leads to increase in incubation rates and feeding of disease-causing mosquitoes, especially at higher temperatures, something which we know as El Nino effect, especially in the context of dengue infection. There is a lot of increase in the incidence and prevalence of arboviral infections all across the world. Meaning the unique centers which were usually described, now it's becoming more and more distributed all over the world. The second factor which needs to be considered is the factor of global travel. We know that medical tourism, leisure travel have removed the restrictions for a lot of these viral infections. They are seen all over the world. Something which might have been seen in North America can be seen in Southeast Asia also now much more commonly. So how do we classify arboviruses? The arbovirus family can be broadly classified as Flaviviridae, Togaviridae, Peribuniaviridae, Phenoviridae, and Reoviridae. We'll deal with only some of the infections which we see very commonly in the Indian subcontinent. The flaviviral infections which can be commonly seen as the West Nile virus, Japanese encephalitis virus. Zika virus has also been reported. Dengue, of course, all of us know is probably the most common arboviral infection which we see all across the world. Some other infections like yellow fever virus, Casanova forest disease has also been described in India. Togaviridae, the most important will be Chikungunya virus, and the other viruses are less commonly seen in India. So what is the map of the distribution of arboviral infections throughout the world? So this is a global map where we see the Southeast Asia and India in specific. What are the common arboviral infections seen here? These are dengue virus, chikungunya, Zika virus, Japanese encephalitis, and West Nile, and Casanova forest disease. So these are some of the arboviral infections which are common to our part of the world. We'll be mainly restricting the next 15 minutes or so to discussion of these arboviral infections and their neurological manifestations. So what is the pathogenesis of these arboviral infections? So usually the vectors are either mosquitoes, either the Aedes mosquito group or the Culex mosquito species, or ticks or sandflies, which attach the skin for a blood meal. The level of viral inoculation is proportionate to the feeding time of these mosquitoes on the host. And it's also important to note that the saliva of these arthropods vectors has some anti-inflammatory and anti-hemostatic properties which can alter human responses. The initial replication of these viruses occurs in the Langerhans dendritic cell, and there is a migration to the local lymph nodes. This is followed by a period of transient viremia, following which there is dissemination of the virus to the reticuloendothelial system. And how does neurological manifestations, especially involving the CNS, occur? It occurs either by direct infection and disruption of the blood-brain barrier, or there could be disruption of the blood-brain barrier due to several other factors, including a systemic immune response, and there could be a paracellular entry for the viral factors. There is a Trojan horse hypothesis in which the migration of the virus can occur along with infected leukocytes. In some cases, especially like West Nile and all, you can have also retrograde transport along the peripheral nerves, just like in rabies. Or sometimes the viral propagation and entry to the CNS can occur through the cribriform plate and the olfactory neurons. So Dr. Priscilla ma'am has worked quite a lot on this regarding how you come across definitions for viral encephalitis, because when the patient comes to you for the first time, you need not necessarily have the definitive etiological agent, like you diagnose a patient to have an acute brain infection or an acute encephalitic syndrome or an acute meningitis. So what is the usual syndromic classification for acute brain infections and the International Encephalitis Consortium consensus definition for presumed encephalitis? These include a combination of factors, including a duration of less than 4 weeks, an acute presentations with fever, history of febrile illness, presence of headache, presence of meningeal signs, altered sensorium or encephalopathy, one or more episodes of seizures, and sometimes even focal neurological deficits. And of course, in your lumbar puncture in case of meningitis, you should also be able to demonstrate that there is some degree of CSF pleocytosis. This can be supported by findings on the neuroimaging as well as sometimes on the EEG as well. So coming on to specific etiological agents per se, we'll deal with arthropod viruses. First virus will be, of course, dengue, which is a flavivirus. It's a single-stranded RNA virus. It has 4 main serotypes, of which dengue virus 2 and dengue virus 3 are associated mostly with neurological infections. The vectors are your Aedes aegypti and Aedes albopictus. And there are 2 cycles, the human mosquito human cycle and the sylvatic cycle, which is the monkey mosquito monkey cycle. And what are the manifestations of dengue as part of the neurological system? The patients most commonly are encephalopathic, which is usually part of a multi-system involvement. The patients are also confused or delirious or sometimes completely comatose as part of the severe systemic dengue infection. But dengue encephalitis is also a well-known entity. Patients can have cerebellitis. You could have patients who are recovering from a systemic dengue infection who go on to develop a stroke. It's usually a hemorrhagic stroke, which is much common than ischemic stroke in these settings. Patients can have Guillain-Barré syndrome and myelitis as usually a para-immune and para-infectious phenomenon. Dengue infections can also involve the eye, causing varying degrees of maculopathies, retinal involvement, and optic neuropathies. And of course, you can have the other peripheral manifestations like myopathy. People can come with severe rhabdomyolysis and be diagnosed to have dengue infections. They can have severe myalgias, as all of us know. And there's also higher incidence of hypokalemic paralysis in these patients. So what is seen with dengue infection, especially with regard to the arbovirus, is that it is one of the infections where neuroinvasion is well proven, both by demonstrating dengue PCR in the CSF as well as autopsy studies, which have shown that the dengue virus has shown to proliferate and replicate within the blood-brain barrier endothelial cells and the neurons. One more important phenomenon, which as clinicians, most of it should know, is that whenever you have that there's a phenomenon of antibody dependent enhancement. So if you have different infections with a second serotype affecting a patient who's already been predisposed to dengue, the manifestations, the inflammatory manifestations might be much more, what you call as ADE or antibody dependent enhancement. One more feature which has been shown in dengue virus is that they can slowly have cytopathic effects within the brain neurons, leading on to slow degeneration and inflammation, what you call as panencephalitis. And you could have variable, diffuse, or multifocal changes, cerebellitis, basal ganglia, hemorrhages, and PRES. So we already described the El Nino effect, the effect of global warming, the warmer summers, very intermittent heavy rain and temperature variations, and all this propagate to more exposure to the vector, meaning much more potency of the vectors to transmit viruses. So that's why the importance of local vector control measures are in the management of prevention of dengue infections. As you can see the global map, actually most of the tropical areas are affected due to dengue virus as of late. So what are the dengue-related neurological spectrum? The pathogens, as we mentioned before, is endothelial dysfunction, capillary leak, increased permeability, release of inflammatory mediators and cytokines. The NS1 antigen, which is a secreted glycoprotein, acts as a cofactor for viral RNA replication, which can trigger a cytokine release and an autoinflammatory cascade. These are some of the depictive images of patients with dengue virus infection, in which the patients can have bilateral cerebellar involvement. There could be bilateral thalamic involvement, diffuse cerebral involvement. They can have something like just seizures and transient encephalopathy, what you call your reversible splenial hyperintensity of the splenium of the corpus callosum being affected here in the top two images. And patients can also have very interesting manifestations like a posterior reversible encephalopathy syndrome. And one unique manifestation which can occur with dengue infection, also common with influenza viruses, is the presentation with acute necrotizing encephalopathy of childhood. Especially in children, they can have bilateral thalamic hyperintensities with hemorrhagic changes in the thalamus. These children usually will be very sick and comatose. The classical radiological finding in all these is something known as the double donut sign or a trilaminar sign, which can be seen in the region of the thalamus. And that shows the trilaminar pattern of restricted diffusion also. So next we go on to Chikungunya virus, which is a toga virus spread by the Aedes mosquito. It was first described in Tanzania, but in India, several outbreaks have occurred, right, starting from around 2005 to 2007. One unique feature of Chikungunya virus is that the infected individuals actually develop a very high degree of viremia, and so they act as reservoirs of infection themselves. Chikungunya virus, we all know the infection is manifested by severe pains and presence of arthropathy. They can have both a meningoencephalitis and neuromyopathy kind of presentation. In elderly population, especially, the manifestations can be very non-specific. Patients can come in with diffuse encephalopathy, some rash, abdominal pain. The manifestations can be more systemic. And virus mutations and candidate vaccines are some of the recent areas of research in Chikungunya virus. So this is a slide showing how there's an increase in Chikungunya infections, especially in areas where there is heavy rainfall and depending on the climate change also. So some specific radiologic, just like dengue, the manifestations are mainly meningoencephalitis, part of systemic inflammatory response, or the peripheral nervous system myositis kind of manifestations, but more commonly myalgias and neuromyositis. In Chikungunya also, you can find some classical radiological features, like in a sagittal section of the MRI, you can find that something known as the glass eel sign. The periphery of the spinal cord, as seen in this image, can have a hyperintensity. When you take an axial section of the same MRI, you can actually find a clock dial kind of pattern because of white matter involvement in these kind of patients. Next, we go on to the Japanese encephalitis, which is a flavivirus, which is spread by the vector being Culex tritonio rhynchus. it is usually very well known to cause a acute encephalitic syndrome, like acute Parkinsonism, viral cause of Parkinsonism. But thankfully, the manifestations of severe clinical manifestations are only in around 1 in 250. Most of the infections are subclinical infections. The areas which are mainly affected are where there are irrigated paddy fields, the reservoirs being birds, herons, pigs, and bats. The transmission, of course, is more in the rainy season, especially in the monsoons. And the humans usually behave as dead-end hosts. They don't help in the propagation of the virus because the viremia, in contrast to something like Chikungunya virus, is usually very transient. But JE, because just as we are showing the image here, because there is severe thalamic and basal ganglia and even brainstem involvement, the patients can have severe Parkinsonism, severe dystonia, and they can be left with severe sequelae also. Almost 30 to 40% of patients with Japanese encephalitis can have severe sequelae. Again, in JE, you have vaccination, which can help out in reducing the incidence of infections. You have better vector control, sanitation, and case management protocols, which can help in individual, meaning better management protocols. So the states affected by Japanese encephalitis, there are many genotypes, genotype 1, genotype 3, genotype 5, etc. Genotype 1 being the more common. So usually you find it in Kerala, Uttar Pradesh, Gorakhpur belt, which is very common. But again, just like any other arboviruses, you can see that the spread has become much more diffuse across the Indian subcontinent also. So JE has a typical pattern of involvement in which you can have involvement of the substantia nigra, brainstem, cerebellum, cerebral cortex, basal ganglia. White matter also can get involved. You can have temporal lobe changes. You can have patients with this bithalamic edema, which almost resembles a deep venous cerebral venous thrombosis. Patients with JE virus can also have a secondary deep venous cerebral venous thrombosis, as seen in this MRI picture, which shows a T2 flare, a diffusion, as well as a ADC sequence showing presence of bilateral thalamic edema. So next we go on to West Nile virus, which is a flavivirus, which has emerged as a major public health threat over the last 2 years or so. It has been seen in India also. You have various, the new variant type and the old variant type. The Culex species again acts as a vector. The birds usually act as the reservoir or the amplifier host, and the humans are affected when there's a spillover from the enzootic human dead end host. So the Indian first case was reported in 1952. We have had outbreaks in Vellore also in reported from 77 to 79, and in the Kolar belt. Majority are asymptomatic or flu-like illnesses, but in less than 1% of patients can develop a severe acute encephalitic syndrome. One peculiar feature of West Nile virus is that patients can come in with acute flaccid paralysis, rhomboencephalitis, or myelitis. Myelitis in which only the anterior horn cells, the gray matter, is involved. The CSF in early phases could have neutrophilic predominance, and you can have either localized or sporadic outbreaks. So you have the old world and the new world strains. The new world strains, the blue strain, which has introduced in the US, North American belt mainly, but it has spread over to the Indian part also. Traditionally, you had West Nile described from Kerala, some areas in Vellore, Assam, and Uttar Pradesh. Here you can see that the new world strain has been described more and more, and you also have the old world strains also for the West Nile virus. Going on to Zika virus, which has been recently reported as something almost like a global epidemic scale. It's also a neurotropic virus due to a single-stranded RNA virus. It's almost mimicking the manifestations of dengue, Japanese encephalitis, and chikungunya spread by the Aedes aegypti mosquito. What is very unusual in Zika is that it is notorious for causing pregnancy-related complications. And in areas where there has been Zika virus, there's been, like in French Polynesia, there's almost been a 20-fold increase in the incidence of patients with Guillain-Barré syndrome after Zika viral infections. There are multiple modes of transmission apart from the vector-borne. Even blood-borne transmission due to blood transfusions or sexual transmission has also been reported in Zika virus. And of late, almost in 2019, non-travel related cases have been reported in Europe. In some cases, Aedes albopictus has also been identified as a vector. So this is how the pandemic, meaning the Zika virus, has propagated throughout the world. It was initially isolated from monkeys. The first case was detected in humans in around 1954, following which there's been multiple areas where there have been epidemics in French Polynesia associated with Guillain-Barré syndrome, as shown here, and in Yap Islands and Micronesia also. And in India also, there's high meaning there is seroprevalence of Zika virus, which has been described. So Zika virus also has an enzootic or sylvatic cycle, the monkeys, and you have the epidemic or human cycle, the mosquito vector being Aedes aegypti and Aedes albopictus. The mosquitoes typically breed in domestic water holding containers. They bite during the day and can feed both indoors and outdoors near dwellings and are present globally. So the manifestations are just like other arboviral infections like dengue and chikungunya. But one feature which can help in differentiating Zika virus is that the proportion of patients having conjunctivitis, severe conjunctivitis, is much more. Rash and conjunctivitis is much more in addition to other systemic manifestations in patients with Zika virus infections. And Zika virus is also transmitted perinatally. So children born to mothers with Zika virus can have what you know as severe congenital infection, in which they can have microcephaly, various malformations, anteverted contractures of the limbs, valgus deformities, and scoliosis. They can have severe cerebral involvement, again shown to be neurotropic in the brain, with underdeveloped hemispheres, cerebellar hypoplasia, and ventriculomegaly. This is from the Lancet 2016 article, in which they were able to demonstrate the Zika virus antigens in the brain neurons. So the other neurological manifestations apart from congenital Zika syndrome include like meningoencephalitis, myelitis, ADM encephalopathy, and you can have peripheral nervous system infections like GBS, as already mentioned before. So I should never be ignored whenever you examine a patient with suspected arboviral infection, because many of these infections, including dengue, Zika, and chikungunya, can have neuro-ophthalmological manifestations. So the manifestations commonly are your conjunctivitis, uveitis, chorioretinitis. Patients can also have optic neuropathy, maculopathy, vasculitis, and hemorrhages. Retinal edema and hemorrhages are also common. So that's the utility of fundoscopy in patients with suspected arboviral infections. So this will be my last slide regarding prevention and treatment. So we know vaccines are there for Japanese encephalitis, yellow fever vaccine, of course, we read about, especially when travel is related. Some vaccines are there for tick-borne encephalitis. The dengue virus, Dengvaxia, is also the live attenuated vaccine which is coming up. There is a lot of emphasis for these prevention of arboviral infections regarding personal protective measures, including optimal clothing, especially during the seasons when they're outdoors, use of repellents, a coordination for better vector control to reduce the breeding areas, and specific insecticide spraying. We all know about the Climb India proposal, of which Dr. Angel Miraculin, my esteemed colleague, is a part of. So it's important to anticipate how climate changing can lead to proliferation of vectors, and how some infections can be more during particular climatic seasons. We have now provision to better point of care tests, which Dr. Asha ma'am will be addressing in the next talk. And the supportive treatment is still the mainstay for most of these arboviral infections, but there are some reports of antivirals and monoclonals, but not much evidence has come through. And whenever we deal with public health, especially with respect to brain infections, we have to be aware of this One Health All initiative, in which there's a collaboration and an understanding that it's just not the humans alone, is there a lot of environmental factors and coordination among multiple departments needed for prevention and optimal management of these infections. Thank you.
Yeah. Thank you, sir. That was a great talk. May I invite some comments from Priscilla ma'am before we move on to the next talk?
Yeah, so hello everyone, and my apologies that my voice is not strong enough. I was supposed to be moderating it, but thankfully Angel has stepped in. So if you have any indication as to how viruses can wreak havoc, just listen to my voice and you'll know. So, I mean, Climb India is indeed a pioneering initiative where we're trying to map brain infections against all the havoc that climate can actually cause. Arboviruses is just one part of it. But increasingly, we are moving towards brain infections and appropriate management and prevention of the various devastation that brain infections can cause, whether it's sequelae, various other brain injuries that it can actually produce. So Ajith has very nicely actually elucidated all the arboviral diseases that can actually happen. And a small part of it has been dealt with. First is appropriate management. So symptom-oriented definitions, which are easy to pick up at the primary care level, such that we can actually recognize these infections easily and then refer them to higher centers for appropriate diagnosis and management. Of course, a key part of it is point of care tests. And we cannot move away from that at all. We cannot diagnose brain infections in the laboratories anymore. We have to diagnose them at the bedsides, at the primary care levels, if you have any hope of actually salvaging these patients for whom brain infections can be a devastating consequence. So thank you, Ajith, for taking us through few of the things. And I think there is no time to dwell on the many viruses that can cause this problem. We've had, colleagues from Karnataka talking to us about Kwashiorkor forest disease, the various encephalitis, which we don't see in Vellore. But, just our neighboring state, we have so much devastation as a result of it. Chandipura, all of these viruses that can actually be seen, and probably we will not recognize it because we have not seen a case like that. But whichever part of the world that you're in, I think move towards a definition, an easy recognition of brain infections, and lobby for point of care tests if we are actually able to move forward. So I'll stop with this and I will hand over back to Angel for people who can actually hear something useful. Yeah, thank you.
Thank you, ma'am. There was one question from the audience. Has Zika been reported from India? So, sir, would you want to answer that live?
Pardon me, Angel, I couldn't see that.
Yes, sir. So the question is, has Zika been reported from India?
Yes. And there's been seroprevalence studies also in which India has been shown there's a lot of seroprevalence of Zika virus in India. Yeah.
Yes. Okay. Thank you, sir.
Zika has been reported in Rajasthan, it's been reported in Kerala.
Maharashtra.
And among returned travelers mainly. But as Dr. Ajith very clearly said, it's been reported for a long time in the 70s in the country. I think a fair degree of seroepidemiology.
Thank you, ma'am. So now we'll move on to the next talk on the diagnostic updates by Dr. Asha. Ma'am, you can share your slides now.
Yeah, sure. I don't know, is this...
So the bottom, the share icon, ma'am, you can just...
Yes, I did... hang on.
Yes.
Is that visible?
Asha, just share your screen.
Share your screen
and click on it rather than just clicking on the presentation.
Yeah.
Okay.
You can just
yeah. Sorry, my bad.
Yes.
Okay. And hang on.
Yes, ma'am.
It's going around a bit. It says I'm sharing, but hang on.
Yes. We can see your screen. Yes.
Yes.
Yes, ma'am.
Okay.
You can put the slideshow
on the... Yeah. Okay. Thank you.
Yes.
So actually, I need to confess right at the beginning that I will be talking about viral CNS infections in general first, and then a little bit about our experience with the arboviral infections. So, well, we're in Vellore, not as big as, say, Bangalore or Chennai, and we have our peculiarities, and I will highlight some of this, particularly as it applies to some of the arthropod-borne viruses. So we'll just look very quickly and briefly at the structures, the cells, the barriers associated, some pathology, transmission routes, and then the specific pathogens that we commonly encounter, and particularly the arboviruses towards the end, actually, and some of the lab methods that we have at the moment and what our experience is. So, I needn't tell anybody, but because the brain and spinal cord are sort of covered with this rigid skull and the spine, any inflammation, any injury can be life-threatening to cells that are very highly complex, that have very refined intracellular communication, that have unique cellular morphology of all the cells in our body, and are anatomically well protected, as we see by the meninges around the brain, and then various other structures, the epidural spaces in the subdural spaces around the spinal cord. So while they're very, very well protected, in a sense, that is what causes the problems when infection sets in. The other thing is, of course, that, cells of the CNS were traditionally thought to be non-dividing, and that may be the case for the neurons, which are post-mitotic. And so there's very minimal DNA synthesis. But that is not the case with, we know that some cell division can happen, especially among some of the other cells of the CNS. So very sophisticated functions, receiving, processing, transmitting electrical signals as well as chemical signals, transmission from one synapse to another and then across cells. So all of these functions by the astrocytes, the oligodendrocytes, the ependymal cells, and the microglial cells are peculiar and very, very important for the brain and the spinal cord. And then, of course, there are the barriers, the blood-brain barrier and the brain-CSF barrier. And so the question is, how do actually these microbes go across? One would be just generally growing across these barriers and then infecting cells that comprise the barrier. There could be passive transport in the intracellular vacuoles. And then, of course, it can be carried by infected white blood cells. So when you look at the pathology, it is infection, whether it is bacterial, fungal, or viral. I'll be, as we are discussing, concentrating mainly on the viral infections. But then very often you can have demyelinating disease and neurodegenerative processes, in addition to, of course, trauma and neoplasias. Now, the main transmission routes involve the blood vessels, the nerves, or local invasion, either across the sinuses or because of congenital defects. And then across the blood-brain barrier, the invasion causes the encephalitis. Across the blood-CSF barrier, it causes meningitis. Just very loosely to talk about the modes of transmission, we know that some viruses can be airborne and some oral, some through breast milk and organ transplants. Now, particularly West Nile virus can be transplanted in organs or transferred through blood products. And then, of course, you have through animals like rabies from cats, actually, and dogs, Nipah through pigs, lymphochoriomeningitis virus through rodents, and Hendra virus through horses. Of course, the herpes simplex viruses by sexual transmission, as would HIV and HDLV be. Blood transfusions, again, West Nile virus can be transmitted in addition to HIV, HDLV, and then, of course, rarely, sorry, that was hepatitis B and C virus. The ocular manifestations, actually, Dr. Sivadasan has already mentioned this, but the other common viruses would be adenovirus, enterovirus 70, and HSV. Now, we're most interested in the group of viruses transmitted by mosquitoes, that is the flaviviruses, which are dengue, JE, West Nile, and Zika, and the toga virus, which is chikungunya. And we shouldn't forget, actually, Kai-Sandwood forest disease as well in our region. And I'll tell you a little bit about these. So we saw that they can cause aseptic meningitis, encephalitis, and flaccid paralysis. Most of these are uncommon complications of very common systemic infections. The most important would be actually to rule out non-viral causes that have specific treatment. So traditionally, even in our lab, we actually started off by setting up a multiplex DNA panel of viruses that detects herpes viruses as well as adeno, because these are the ones that have treatment available. Just to very quickly mention that some of the particular regions that infect the brain, the cortical region, you would think of the alpha viruses, HSV and JEV, as well as West Nile. Meninges are infected by the enteroviruses, Japanese encephalitis, mumps, Nipah viruses, the ependyma by CMV, enteroviruses and mumps virus, cerebellum by enteroviruses and West Nile virus, the brainstem, particularly enteroviruses, of course, the polioviruses being a specific example of the enteroviruses, rabies virus, West Nile virus, and the spinal cord, EBV, CMV, HIV. Other areas like the hippocampus, particularly enterovirus, rabies, West Nile. The thalamus would be enterovirus, rabies, and West Nile again. Microglia by HIV. The oligodendrocytes by JC virus. And yes, we will, we all know that, for example, the temporal lobe involvement, very often is what you see with HSV and advanced disease. But the other viruses I will be mentioning will be CMV, rabies, VZV, EBV, and yes, varicella zoster virus. Then, of course, there are particular nerves that actually disseminate particular viruses. HSV along the trigeminal, rabies, of course, along cutaneous and cranial nerves, varicella zoster virus along cutaneous nerves, enteroviruses along trigeminal nerves, and I mean, when not really doing anything with prions, but that along the splenic nerve. I'll skip this, but we will go on to some of the lab tests that we have for diagnosis of CNS infections. Now, most labs, especially in the 1950s, 1970s, actually used microscopic examination. And the thing about that is that these tests are easy to perform, and any routine lab can do this within a turnaround time of maybe 0.5 to 1, half an hour to an hour. And this result is a direct detection. It is rapid, but has very poor sensitivity and specificity. And one of the things that we need to remember is that, where you can do a culture for direct detection of some viruses, you could look for antibodies. And one of the problems with serology will be highlighted shortly. Now, rapid antigen detection tests can again be done by routine labs, and turnaround times are anything from 15 minutes to 30 minutes. Although I do need to say, no lab is actually waiting for a particular sample of a particular patient to come in. There already is a workload, and that is one reason why actually, even when tests are costed, we actually look to see what is the batch number that is reasonable for a particular test. And so the more advanced tests become, for example, if you're looking at the other end of the spectrum of genomic detection and sequencing, the more viable it is to batch test and do, because the individual assay becomes too expensive for most patients. So rapid antigen detection tests, I mean, by its name, they can be done quickly, but there is false positivity in some cases. In fact, there is also, and particularly for the arboviruses, there is very low sensitivity also. Culture methods, again, can be done, but it's because they take a long time. And particularly for viruses, some can take up to 3 weeks to grow. So, I mean, who's going to wait for 3 weeks, right? And it needs more sophisticated facilities. It is, again, direct, evidence of the virus. So if it is culturable and you find it, that is a definite diagnosis. But nowadays, it is mainly used for phenotypic drug susceptibility testing. It's time consuming. It's very, very low sensitivity. And not all viruses, for example, or even some bacteria are not culturable. So the other thing is that you need monoclonals to identify them definitively, and those are enormously expensive. And we know as the years go by, as very, very few labs do this, actually they may not even be available in our country. Now, serology is by and large the most routinely used assay. It can take anywhere up to 8 hours to do these serologies. They are indirect evidence of the virus. And if automation is available, that is well and good. But let me tell you that right now, there is no automation available for any of the flavivirus assays, except maybe West Nile. So it's often manual. And if you have a virus like dengue, which we do NS1, IgM capture, and IgG capture, during the dengue season, for all intents and purposes, 3 people are just working through the working day doing these assays to get these ready for reporting on a daily basis. So manual assays are cumbersome. And the other point is, among the flaviviruses, there is a lot of cross-reactivity. So we know this exists between dengue and Zika, and to some extent, JE, as well as, between these main flavivirus groups. So a lot of the studies from the 1970s were actually serology based. So when, for example, a public health survey was done in Vellore and they found JE, very, very few cases. In fact, I think in that period of time, 2 cases of JE were found. But if it is based on even IgM capture, there is a strong likelihood that there is cross-reactivity. So unless you check also for dengue, as well as JE and West Nile, you can't really say, is this truly JE or is this truly dengue? So there is cross-reactivity. And the other problem with serology, of course, is that among the immunosuppressed, the antibody response may be subminimal. Finally, we have molecular tests, which some assays are point of care and require more sophisticated labs. They also take about 2 to 8 hours. And again, this is direct evidence of the virus, but you don't know if that virus is actively replicating unless you're looking at mRNA. They're very highly sensitive, very highly specific, but the clinical relevance has to be determined by looking at the clinical features. In fact, most of the flaviviruses do not have routine point-of-care molecular assays available at the moment. Now, I'll just tell you some things about some of the results we have found from the CSFs that have come into our lab. In 2023, about 59% were EBV, followed by adenovirus, CMV virus, varicella zoster. We did have 1 request routinely for dengue. We didn't have much enterovirus that year, but we had some JC as well, no West Nile that particular year. In 2024, again, it was EBV, CMV, adeno, and varicella zoster. We had enteroviruses and West Nile detected that year. And in 2025, Again, the DNA viruses, which were VZV, EBV, adeno, CMV, but we also had an outbreak of enteroviruses, and so therefore had something like 18 enterovirus positive CSFs from child health, and no West Nile last year, sorry. So now, EBV is something we are always asked about. Why do you report it when, you don't know what its significance is? The thing is, it is found positive when there's more pleocytosis, when the proteins are elevated, when glucose is less, when there is RBC contamination. And so therefore the WBC count has to be corrected for this. It is associated with CNS lymphoma, myelitis, but also in secondary viral reactivation, in brachial plexopathy and Guillain-Barré syndrome. Now, the thing is, very often the significance of EBV can be much later than its presence in the CSF. And so we leave that to clinicians to decide, is this significant or not? Okay. Now, varicella zoster, between 9 to 13% of our positives are varicella zoster, which can cause meningitis, encephalitis, cerebralitis. Now, the higher the burden, the higher the propensity for stroke. And actually, I think the last few years we've been having a lot of VZV because neurology are looking for VZV among young adults with stroke. And the other thing that publications say is that, the higher viral burden is indicative of a higher propensity for stroke. And the CTUs, which is the cycle threshold by PCR, is anything less than 35. Now, I just want to make a point that unless you do a quantitative PCR, you really can't compare between assays. But having said that, if you have an assay which is well accredited with, good interlab comparison, covered by good external quality assurance programs, you could say that, something less than, say, maybe 30 is low CT, and something maybe above 35 is a high CT. And therefore, the low CT, the lower the CT, the higher the viral burden, the higher the CT, the lower the viral burden. We have quantitative assays at the moment for CMV, EBV, and BK because our transplant population requires this for monitoring. But VZV is another pathogen that we are actually considering setting up a quantitative PCR for. Again, CMV, between 9 to 12% of positives. It causes meningoencephalitis, especially in the immunocompromised, worse outcome compared to EV, HSV, and VZV positive patients, that is positive in CSF of patients. And then, of course, there's the congenital neurodevelopmental disorder it can cause, and the polyradiculitis. Adenovirus is positive between 2 to 16% of our total positives. Again, encephalitis, meningitis, anterior myelitis. Children are more actually affected. We see this is associated with respiratory disease. Very often, if we test respiratory samples and CNS and requested to, you can find both are positive, and it can contribute to Reye syndrome. Now, the other pathogens we find, enterovirus was 15% of our 2025 positives. We think there was an outbreak. It's actually sort of petering out now. But the other thing, the other related enterovirus is parvovirus, which we found in an adult with meningitis and in a child with meningoencephalitis. And these were the first cases of acute CNS infections caused by parechovirus in India. Previously, it was associated with GI infections per se. West Nile, we found 1% in 2024, but between 2015 and 2017, we had 4 cases which were acute meningoencephalitis cases and have been reported from our lab. So now the thing is, as I mentioned earlier, herpes viruses and adenoviruses, we have a multiplex. We actually have a multiplex RNA evaluated, and what we found was that this was a student of ours who'd done it. When we add serologies for the arboviruses, so among the multiplex and singleplex, that is single pathogen detected, among the PCRs, we got about 25% of an etiology in CNS infections. When we add serologies for dengue, JE, West Nile, and Zika, this increased, this detected about 15% positive. So our virus causation increased from about 17% to 40%. And 19% of these were arboviruses, that is dengue, JE, West Nile, Zika, and Chikungunya. 17% were herpes viruses, 3 to 4% were enteroviruses, and parechoviruses. So just to mention this, and that is, we checked for KFD in about 2,500 samples and got 1 positive. And that 1 positive PCR was in a patient with dengue-like illness. Unfortunately, that wasn't published, but and that was because we used up all the sample in the testing. Now, in the same group, we tested for Zika. So in about 2,500 samples, we didn't get any that were PCR positive for Zika. So we think KFD may be here, particularly important because these ticks are found in, traditional mud type houses or wherever there is a lot of, in a rural and semi-rural area. So these are my references, and I will take any questions if there are any.
Thank you, ma'am. That was a great overview of the whole diagnostic armamentary. So I think there are 2 questions. So how
Yes.
to deal with cross-reactivity between the viruses and sometimes with lepto?
Yes, and that's the other thing. I mean, I didn't bring in malaria and lepto and, scrub. The short answer is, well, actually, the short answer is not so short. You need to test them all. Traditionally, that is what is done. Of course, if you get a PCR positive in any of these and in CSF, you can, you can sort of pin it down to that particular pathogen. What we are doing is we're actually trying to see if we can design an ELISA which is less cross-reactive. But I mean, it requires a lot of bioinformatics, and that's something that we are embarking on, and a project that a student is actually undertaken, much to our horror, because that's not quite, what shall I say? That's not quite our area of expertise. So we've been having to rope in people from, VIT and other institutions, to do this. But yes, very, very important to address that concretely.
The second question is, can climate change affect the false positive rates of lab tests for neurological viruses, and how to handle these climatic factors from sample collection to transport?
See, so here's some of the basics that I didn't touch upon, but we face every day. If you want a good PCR result on CSF, that CSF has to be transported cold. Okay. Now, the issue of whether cross-reactivity will be more with climate change is actually a moot question, in the sense that the viruses are already expanding in their what shall I say, in the regions that, I mean, as climate change changes the isotherms northwards in the north hemisphere and southwards in the southern hemisphere. Dengue is endemic, and dengue is now seen in some parts of America, Florida, Hawaii, parts of Europe have had chikungunya transported from the Reunion Islands. So you're going to see this in more and more areas. It doesn't have to do with the fact that cross-reactivity will increase. The cross-reactivity is a function of what peptides are there in your ELISAs. Okay. If you have PCRs, your sensitivity and specificity are going to be much better, and you're not going to see that much cross-reactivity. Having said that, there may be a 0.01% chance that you have the same, the same sequence in some bacterium, and you might have some cross-reactivity, but it's much less with PCR than with your serology. Now, this is the problem with the rapid point-of-care tests. Right now, abysmal. I mean, we found for dengue 40% sensitivity, so of course then your specificity may be a little higher, but you've got better chances flipping a coin, right? Yeah.
Thank you, ma'am. So one more question about parvovirus CNS infection. Were these patients immunocompromised? Any specific risk factors were seen in them?
No, not that. No, they were not immunocompromised patients. Although actually, I think one patient did have. I have to go back and check. But
that this is Dr. Panmay's publication, no, ma'am. So actually, it's a community acquired. Is
correct.
What I understand.
Correct. It was community acquired.
And just a question for Ajith sir. So good session about arboviral encephalitis. Can you discuss a bit more about West Nile and what is the approach to order the test in a patient with encephalitis, and what might be the clinical clue?
Yeah, in terms of West Nile encephalitis, again, majority are asymptomatic with West Nile infection, but those who are symptomatic with a nervous system manifestation include either a acute meningoencephalitic syndrome or acute flaccid paralysis. So these two are the manifestations. So imaging in these kind of patients might show hyperintensities involving and mainly the gray matter could be in the anterior horn cells of the spinal cord, the brainstem nuclei, or even the thalamus. So that'll be the manifestation. Many of these patients with West Nile encephalitis, meningoencephalitis, especially in the early phase, their CSF can be neutrophilic also. So that's one clinical clue in terms of the presentation with meningoencephalitis with spinal cord gray matter involvement. It can be something similar to enterovirus also, like enterovirus 72 and all, in which you can have flaccid quadriparesis and meningoencephalitis with an early, meaning a CSF early into disease, which might show a neutrophilic pleocytosis. The sugar might be just borderline low, the protein might be mildly elevated. So this will be the clinical picture. The test, as Asha ma'am mentioned just now, we could order either a PCR or a serology. Both might be helpful in the diagnosis of West Nile encephalitis.
Yeah, thank you, sir. So I think we have a Dr. Rajpal who wanted to ask a live question. So, sir, you've been. Can you unmute yourself and ask your question? Yes.
Right. Right. So, I mean, nice talk, Dr. Asha. Actually, I have attended half of the talk of Dr. Vijay. So basically, I mean, a nice talk and nice meeting to you when I was in CMC Vellore. Unfortunately, I didn't get time to visit your lab. So maybe next time, definitely I'll come. So the thing is actually, I don't know whether I have missed it or what. The HSV cases you have very less, as you have indicated in your slide. Is it correct, or I missed it something?
Sorry, are we missing something? Is that your question?
HSV, I missed it. Maybe. I mean, I saw some table where you are indicating different types of infection, neuroinfections.
Correct.
So you have less HSVs as compared to others.
Yes. And this is, corroborated by the literature that says that it is only seen in it's not associated with epidemics.
Yeah.
Most of us actually have antibodies to HSV1 and 2, which seem to be protective. So it will be in the case of, say a pregnant woman who has HSV lesions in her genital tract, and the baby is passing through, and then maybe it infects through the eyes or the mouth. Okay. But yes, our prevalence of HSV is low.
Okay, right. Thank you. And like you are talking about with someone about the sensitivity of the two tests, basically, has anybody done some kind of a concordance? Because we know it depends on the stage of the infection, right? Sometimes you get antibody or antigen or then genetic material and all these things. So to your experience, do you think a combined approach will be a better approach?
Indeed. I mean, that's what our student has shown, that if you combine serology and PCR, you will have a better approach. The problem is all these serologies are done manually. Okay. And at the moment, many of these PCRs are manual. So when you have, a large lab dealing with a large number of samples, if you don't batch test and do, you're not going to be able to manage. Doing manual assays round the clock. I mean, and it's not round the clock, right? It can't be. I mean, we do the rapid blood-borne viral screenings because there are automated tests available. But as long as they are manual, I mean, one of the things with this CLIMB study, I'm hoping is that we come up with something that is, a robust assay that can be translated to an automated test. Then in that case, I mean, big labs can deal with it, and then we can hope to do PCRs along with serologies and give a diagnosis in a more timely fashion. But until then, PCRs are done, say, twice a week, but serologies can be as, it may even be once a week, depending on what assay it is. So it's all dependent on how expensive these tests are, right?
Exactly. Right.
Yeah.
Thank you.
Thank
And
you.
the last thing for my knowledge, actually, I'm also working on these things. Have you seen HIV antibody expression or positive PCR in CSF in HIV positive cases?
I have not looked for it, but I don't know. Ajith, you could, a child. I'm pretty sure that you can, but I don't know what the prevalence is, and I haven't looked recently.
No, that's what I wanted to know, because I'm working on it and neuro HIV cases and all these things. So in some we have reported. So that's what I just wanted to know. We have just started 3-4 months before. We had old samples of HIV and CSC parallel samples and all these things. So thank you. I mean, one short question to Dr. Ajith. If he's here. Hi, Dr. Ajith.
Hi, sir. Hi, sir.
Hi. It was nice meeting to you in CMC Vellore, even though we don't have much time to talk about the subject and all these things. It was a short visit. I hope Dr. Angel will invite me again, and then we'll have an in-depth talk about all subject. Just wanted to know about the West Nile. Have you seen this is in a same family case? I mean, 2-3 cases in a same family, and you have that kind of data?
So very few cases where I think Dr. Asha showed a paper from Dr. Shobha Maman from virology. We have had almost 2 cases in the last 4 years, meaning at least who have got picked up serologically to be West Nile. We couldn't find any interfamilial, meaning the same family, multiple members. These were sporadic cases to my knowledge.
Okay, right. Thank you so much. Thank you, Angel.
Thank you,
Thank you,
sir.
sir. Thank you. Yeah. So we'll take one more question. Maybe Dr. Priscilla can take this question. So in many cases, patients reach tertiary care hospital after 2 or 3 weeks with sequelae. How to prove that time regarding viral encephalitis? And is there any role of viral specific IgG? And what is the CMC Vellore institutional approach in these type of cases? And I will club it with one more question. Sometimes more than one organism comes positive on multiplex PCR. How to handle it in a clinical setting, especially when the MRI and clinical picture doesn't add much. So we can take all the opinions of the panelists regarding these two questions. Yeah.
Okay, so thank you, Angel. So the short answer is it's very difficult to figure out what is the likely causative organism of a viral encephalitis once you present late. Now, we know that in many instances, the serology doesn't mean anything. And I think Asha made a very important point continuously throughout, I think, saying that serology can be misleading unless it is an acute event. So you can't get away from clinical features, the risk factors, and then doing serology or PCR tests that are available. But looking at it in totality is actually very, very important for you to figure out whether it is actually related to a particular pathogen or not. Now, for example, I think Dr. Rajpal was talking about HSV and why is it that it is low? It is actually, for a very long time, we did not really suspect that scrub typhus was the most important cause of an encephalitic syndrome. It's a matter is as simple as that. And we always assumed that since HSV was the most treatable, the chances that it is actually, HSV is the one that is causing all the disease is more likely. So I think it's very important to actually, what do we do as an institution? I think we have excellent clinicians. I think that's the primary thing. We are really fortunate to have fabulous lab as well. So clinical input along with laboratory is extremely important for us to actually make a diagnosis, to rule in the diagnosis. If you've gone through the BI Global paper, you will see the approach that we had taken. We had actually pathogen panels, which were based on our experience. So the first time what we did was an observational phase. We saw what was happening, put in together the clinical data, and finally came up with panels which we felt were applicable to the country as a whole. Similar panels have actually now come out even by ICMR. So whatever we found in BI Global, which was just 2 center, ICMR has actually now made that widespread with lots of institutions part of this surveillance network. So I think clinical input, clinical clues, along with lab tests is very, very important to actually make a diagnosis. Now, I'm going to say the same thing for the second question. If you have more than one organism, I know a lot of the time there is a problem with serology in an endemic area. You may have a dengue positivity, you may have a scrub typhus positivity, and we know both of them can actually produce neurological sequelae. But putting together the incubation period along with the clinical clues becomes really, really important to rule one diagnosis in. So in fact, in our, when we did the BI Global study, we actually, along with the results, we used to have a very detailed panel review. And I think Ajith and Angel will remember some of those things. Where we had a group of physicians coming together and saying, okay, look, what do we think it is? Do we think it's dengue? Do we think it's scrub typhus? And very often we would actually give just one diagnosis because we believe that that is more likely in keeping with the primary pathology or the primary clinical picture. So I think clinical input becomes very, very important when you have confusing serological diagnosis. So I'll start with that.
So, any comments from Dr. Ajith, Dr. Asha?
Thank you.
Thank you. Ma'am, anything?
Just one comment, and that is, that what shall I say, holistic view actually takes a lot of time. I mean, it requires a lot of, looking at all the possibilities along with whatever tests are available, but is difficult to do on a sort of daily basis for every patient and every sample that we get. Just that. I mean, yeah, that's
I think
it.
that's for the clinician to do it. So I think we do that every day anyway. You know, you have an Aspergillus PCR positive, which doesn't fit in with the clinical diagnosis, then you may ignore it. So I think these are the decisions clinicians make every single day. And it's very important to give, especially in the primary care centers, physicians the confidence that, look, your clinical diagnosis may actually be right. So stick to it and use the lab as an adjunctive test to what you suspect should be your primary clinical diagnosis. I think it's a very important message to actually convey.
Okay, sure. Thank you. I thank the panelists, Dr. Priscilla, Dr. Ajith, Dr. Asha. I think it was a enriching seminar, and we hope to continue this on a monthly basis. So the next webinar will be hosted by AIMS Delhi. So we'll put out the brochures shortly. Thank you all for attending, and see you all.
Thank you.
Thank you.